A very welcome to all of you. This is the EAU webinar Living with Prostate Cancer, Understanding Fear and Strategies to Support Your Patients. We have a very exciting presentation tonight with Louisa Fleur from London, Dr. Alex King from London, and Nicole Clark from the Netherlands. Our program is that 7:05, Dr. Alex King will present his presentation, Fear of Cancer Recurrence, FCR, and Fear of Disease Progression, FOD. And Alex works at Imperial College Healthcare Hospitals in London. Alex is a consultant clinical psychologist, an expert in all psychological and social aspects of personal and family adjustment to cancer, diagnosis and its consequences, including treatment, decision-making, stress and coping, adjustment and recovery. And Alex, I'm quite sure that if you have anything to add, you will do that when you start your presentation. At 7:20, we got Louisa Fleur from London. Louisa is the lead uro-oncology clinical nurse specialist at Guy's and St. Thomas NHS Trust in London. Susan has an invaluable experience in prostate cancer patients and survivorship. She runs a number of nurse-led clinics where she looks after men on hormone therapy and address their unmet needs. At 7:35, we have Nicole Clark, metastatic CRPC, what is important and how do we support patients and families. And Nicole is a case manager in uro-oncology at the outpatient clinic at Medisch Spectrum 20 in Enschede, the Netherlands. She has been working there for 5 years and have experience in urology and oncology nurse for almost 20 years. She's in contact with patients and their families throughout the whole treatment. And her special field is and interest is in prostate cancer and be able to discuss erectile dysfunction. So after the presentation, we got 10 minutes for discussion with the panel. So please, Alex, you can start your presentation when I stop sharing mine.
Terrific. Well, thank you very much, Brigitte, and thank you all for kind of having me. It's you know, as always, a sort of I wish I was sort of there looking at people, but I can see we've also got almost sort of about 100 people with us, which is terrific. So hello, everybody from London. Let me get that kind of presentation going up there. Terrific. So I hope that looks okay. Brigitte very kindly introduced me as coming from Imperial College Healthcare. It's an acute cancer center in London, and we've got a cancer psychology team there. And you know, fear of cancer recurrence, fear of cancer progression is a very big topic. It's always kind of there to some degree. So I'm going to try and use some of the ideas that we've learned to talk about helping men live well after prostate cancer by responding effectively to fears of progression. Oh yes, disclosures, there we go. Now, I think that before we go into something very specific, such as the kind of fear of progression or recurrence, we've got to put that in the context of the overall experience of living with and beyond cancer, right? And we did a piece of work which my colleague Claire Leboutillier led that analyzed about 70 papers where researchers had done kind of in-depth qualitative exploration of patient experiences of various aspects of cancer. So when you take them all together and you kind of synthesize those in those sort of accounts, what we came up with was a sort of 3 overarching themes. And one was the experience of adversity. We called the theme adversity, which is kind of the various things that people experienced as they were gradually realizing the impact of cancer and their treatments. So kind of making sense of cancer, making sense of the treatments. Restoration was the theme of learning what you can do to cope with the new challenges. So there's an element of trial and error, learning information, advice, things that you're notice the word gradually is very important, that you kind of repeatedly and ongoing learning as you go through this experience. There's no such thing as, I was well informed until it's after it's happened. And compatibility is very important. It often gets sort of left out, but if you really look carefully at the accounts of people, being affected as a person, one's identity, and sort of reflecting on that is, again, an ongoing process, and sometimes very shocking and sometimes very slow, and sometimes it happens later. But, it's a very common thread in the experience that there's a reflection on identity. So if you look particularly, at sort of prostate cancer, what might, you wouldn't be surprised to hear people talking about the shock, the difficulties they had in making a decision about treatment, perhaps, if they had a choice, that they had persistent side effects, sexual function, the fatigue, their body shape, perhaps, the biological impact of hormones if they're on them, such as mood, cognition, and sleep, and many other things. So they sort of talk about how these things felt, right? It's the huge burden of this could at times, and other times very minimal burden, right? But there is something there about kind of realizing that impact and kind of learning what you can do with it. So the adversity and restoration. And then under compatibility, you wouldn't be surprised to find that people talked about feeling more vulnerable, feeling they've kind of lost control, or at least kind of given up control to their doctors and nurses, that they had to deal with a lot of impact on how they felt about their role in work, family, and other social roles. And the fact that, as recovery came, restoring the roles wasn't sort of easy. You didn't easily slot back into the life you had before, even if things medically were treated effectively. So in this context, right, we want to define fear of cancer recurrence, and I'll use these terms kind of a bit loosely and interchangeably. Fear of cancer recurrence or fear of cancer progression. That it is the fear, worry, concern relating to the possibility that cancer will come back or progress. That's the kind of working definition. Labelle is one of the kind of key researchers in this area. And I think we recognize that fundamentally at the core of this, it's not really about statistics. It's about the existential fear of loss and death and suffering. So it's kind of how people are expressing and managing that fear. And it is a very common concern. That's why it's sort of so varied in range between studies, depending on who and when you ask. And, one of the most common tools, so the patient-reported outcome measures, is the fear cancer recurrence inventory. So I've put the references there and the latest review paper, and there's some kind of different sort of cutoff points. So if you're using that or thinking about using that, that might help you. And what would we say is kind of normal? Because I think that on some level we'd all sort of want to say that, such as the sort of threat of cancer, even for eminently treatable and curable cancers, that there will be something normal about feeling anxious, right? About feeling threatened, about responding to that sort of threat. So normal usually is, having occasional feelings of vulnerability, sort of reflections on loss, concerns about the future. But those are usually only or mostly around relevant event triggers, like a diagnosis or a checkup, or kind of being at the hospital again, or specifically being reminded, and they generally subside. And actually, that kind of low, relatively, unintrusive or sort of short-lived may motivate and sustain health behavior change. So if people want to improve their exercise and diet, occasional feelings of vulnerability are kind of an aspect of their motivation. However, when it reaches intense preoccupation, sort of rumination or intrusive thoughts, where people kind of feel that they're constantly thinking about it, particularly when what they do, how they cope, is maladaptive. So hypervigilance, kind of monitoring very, very closely their body for signs and symptoms, or the opposite, absolute avoidance, and usually fluctuating between the two. Functional impairment in the sense of kind of worry or anxiety, interfering perhaps with your attention and concentration at work, excessive distress, difficulties with planning ahead. So people might say, I don't really want to make plans because you never know what happens. And all you're really, you're talking about kind of, say, attending a friend's, birthday event next year. And because of kind of how distressing and how intensely anxiety provoking it is, this will not help sustain behavior change. And that's kind of perhaps one of the paradoxes. The more worried you are, perhaps the harder it is to sustain behavior change. And your worry is perceived as uncontrollable, with a quality of obsessiveness, perhaps. Now, as experienced practitioners, you'll have a feel for this. But if you wanted to, get a bit more of a measure on it, this is the fear of cancer occurrence in the short form. As I said, it's a pretty simple thing. You can kind of get it from there. Now, when people do use it in populations, and this is several populations, and I'll kind of pick out prostate cancer, and we'll see that among survivors, people kind of living beyond prostate cancer, you've got something like going from the over 22 score, which we said is the kind of severe or clinical. It's about 7%, but a sort of significant degree, 17% or in the middle, and lower than 13, which is again what we would say sort of normal or mild. It's about 63%. So overall, about 40% have some degree of significant fear. In patients, it's not that massively different, sort of surprisingly. So people are actually having treatment. So, that gives you a bit of a sort of a rule of thumb that, everybody will to some degree experience that, but for about 40%, it'll be troublesome. And for about sort of 7 to 10%, it'll be really, really troublesome. Who perhaps more? Younger patients, right? As always, distress is much more likely to happen to younger people who don't expect a cancer diagnosis. Perhaps they had an abstract sense of, well, one day I might get ill, but you generally have a sense of invulnerability as a human being, otherwise you wouldn't carry on. And so that fact that, if this has happened to me, then other bad things can happen to me. This was not expected, so other unexpected bad things can happen to me. So even low risks of recurrence, objective low risks, can be high and frightening subjectively. The same for people with past experiences that made them feel vulnerable to traumas. They're entirely unrelated, perhaps, with cancer, but give people a higher subjective perception of risk. Sort of bad things happen to me, I'm vulnerable and anxious. And that trauma will be encoded in their memories and, not really going to easily respond to reassurance. Side effects, of course, so something that gives you continual niggles, obviously keeps your sort of fears active. A higher level of education tends to be associated to lower fear of cancer occurrence. So the reverse, lower education, more fear of cancer occurrence. Limited social support is usually a massive issue in distress generally. And one spouse, the partner not affected by cancer, can often be very worried about this, perhaps in interesting and complex patterns. So looking out for that in spouses as well. So if we were to look at this kind of as a psychological model, how psychologists might like to have kind of ideas about how the mind works, what we'd see is that the fear of cancer occurrence comes up for a variety of factors. So the triggers we talked about, the perception of the illness as uncertain, heightened perceived risk of recurrence, also a little box there to the left where people have positive beliefs about the benefits of worrying. That's crucial. So the fundamental idea that if I worry, I'm looking out for bad things happening and I have a better chance of preventing them. Intolerance of uncertainty and checking and reassurance and avoidance as the behaviors. So, this is a sort of research-derived model that also makes sense conceptually. And usually what happens in practice, is that doctors and nurses will educate patients about the disease risk and reassure them. And they say, no, don't be worried. This is pretty low risk. This will be fine. And that's okay. That's good. And some people, can take that and use that and be sufficient with it. But if indeed you're worried about people, you need to hit a few more of those boxes with psychoeducation and behavioral direction. And I'll tell you what these are. The first thing is you really, really need to listen and validate that fear. You need to really understand how the person's feeling, for better or worse, what the impact, and validate the fact that for them, this is hard, this is scary, this is a struggle. All too often, people are sort of reassured too quickly. Their family and friends want them to be okay, want them to not worry. They'll say, there, don't worry. So unless you really hear the degree of fear and worry, people are not going to hear you in return. Then psychoeducation, always that process of kind of talking to people, but also starting from where they're at. So what do you know about this illness? What do you think are the odds? How do you think it might come back? And then you kind of really absorb those things and you say, yes, I understand what you're thinking. And then, but here's some sort of extra information. And particularly you want to help them understand risk and the signs and symptoms, and really talk about that idea that worrying is a way to stay alert and safe. And it's understandable that people might do that, but it's not really very effective. In fact, it keeps them kind of looking out all the time over their shoulders, and what a way to live. And behavioral direction is the bit where you kind of talk to people about, of course it's important to protect yourself, but let's do it effectively. Let's do it practically. Let's kind of make a plan that's going to be really reassuring in a practical way, because, war is not that effective. So talk to them about safe checking, when is and how much is appropriate to check and how. People are going to Google, so talk to them about useful Googling. Some people like peer support and the value of that. So, explain that, and they can learn from other people about how they manage fears. And talk to them about avoiding avoidance. And that means, don't try and suppress and deny your own fears. Just sort of acknowledge that you're scared about something, and then, reassure yourself with what you know and focus on the present, focus on what you want to be doing. So rather than suppressing and avoiding and saying it's going to be fine, just sort of saying, I am scared, but I know that I'm going to be looked after, and, I'd rather really spend my time thinking about my day to day rather than, all the catastrophes that might happen in the future, and involving others to support you in that, and asking for help effectively. And that means kind of, when do you come back to clinic? When do you reach out to your nurse? When might it be bad enough to seek the advice of a psychologist? And indeed, that would happen if not only do you have that kind of signs of clinical function of fear of cancer occurrence, but also psychosocial vulnerabilities like a mental health history or social isolation. That is worth considering a specialist psychology referral. So I hope I've done okay-ish for time. Obviously, it's quite quite the task to compress this in 15 minutes. Here's a nice video I found where a sort of social worker from the US sort of talks about fear of cancer occurrence in a video to patients. So, have a look at that. You might pick up some interesting techniques. A lot of it is, of course, relevant to that particular cancer center, but the general principles are good. And here's another really good one, or sort of slightly longer lecture in fear of cancer occurrence that might guide you through a little bit more of this if you want to delve deeper. So thank you very much for attending. We'll pick up questions and discussions later. And for now, I will hand over to Louisa.
Thanks, Alex. Amazing as ever. So I'm Louisa. I'm actually a consultant nurse at Guy's and St Thomas's, recent promotion, thank you. and I'm going to talk about non-metastatic castration-resistant prostate cancer and how we manage and support patients. And as Alex has said, 15 minutes isn't very long, so we're going to just talk about some of the themes and hopefully just get some discussion going on that. These are my disclosures. So what I'm going to try and cover here is a little bit about what non-metastatic castration-resistant prostate cancer is and what the challenges that can bring. And also, probably most importantly, how patient management can be optimised, hopefully using a sort of person-centred approach to care. We're going to try and look at some of the data and think about what that actually means for our patients. So the first thing to sort of think about is, who are these men with non-metastatic prostate cancer? So there's two reasons why men without metastases, or two main reasons why men without metastases might end up on androgen deprivation therapy. The first is they might have a diagnosis of non-metastatic disease, and they might be unfit, unwilling, or unable to have radical treatment. And if they are unwilling or unable to have radical treatment, they might be treated with ADT because they've got high-risk disease, or it may be patient choice. There might be a degree of anxiety about living with prostate cancer without treatment. The other major group that we might see are men that have had treatment for prostate cancer, but they've had biochemical or local progression after either treatment or watchful waiting or surveillance. And again, they might have ADT because they can't have any further treatment for whatever reason, and because they've got high-risk disease, or again, because of patient choice. So this is the main two reasons we might be looking at men on ADT without metastases. So their pathway tends to be a kind of diagnosis of whatever that might be. We initiate treatment, we do some follow-up and monitoring. Eventually the PSA will rise, there might be some imaging, and then they might get referred on for further systemic treatment. And running along through that is this idea of holistic support, and we'll come back to this diagram. But underneath, I've just put some arrows just showing that the ADT process, if you like, is they start off as what we call hormone therapy naive, so they've never had hormone therapy. We start treatment and they're hormone sensitive, which means they respond to hormone therapy, and then they become castration resistant. And that's what we're talking about today. So what is non-metastatic castration resistant prostate cancer? I'm also going to have a little look at high risk, because that's really important, particularly in light of some of the things that Alex has just said about that fear, which lots of these patients will be living with constantly. So the definition of castration resistant prostate cancer is when you've got a low testosterone, a castrate testosterone, and you've got a rising PSA. And we generally say 3 consecutive rises and PSA above 2. But importantly, there's no metastases. And we usually say there's no metastases as defined on conventional imaging, so bone scan, CT, MRI. So if your patient has been on ADT, their PSA is going up despite castration, and they've got no metastases, they are classed as NM CRPC, non-metastatic castration resistant. So that's interesting, but that's a huge number of patients with very, very different disease. So it's really interesting to think about who is high risk. So for the patient, they will all feel like they're high risk because we've been telling them for ages that their PSA is important, and suddenly it's going up. So this paper, which was published 9 years ago now, showed really nicely how the rate of change of the PSA doubling time is a very, very good predictor of of the risk of developing metastases. And you can see on this diagram here that the shorter the doubling time, so the quicker the PSA goes up, suddenly when you hit sort of 10, 9, 8 months, the risk of metastases really, really goes up exponentially. So this is the high risk bit. This is the men that are at risk of developing metastases. So why is that important? Well, it's important because we know that slowing down the development of metastases is really important, because for most of these men, they're asymptomatic for their prostate cancer. They may have side effects from ADT, but the prostate cancer might be giving them some local symptoms, but they haven't got metastases, so they haven't got all their burden that comes with that. So if we can slow down the development of metastases, it will maintain quality of life, it'll delay the impact of things like pain, etc., and hopefully also help men live longer. So this is all really important data that we need to understand in order to educate our patients about what their follow-up means and how we can support them. So just quickly going to talk about trials, and then we'll talk a little bit more about what this means for the patient. So there are 3 big trials that have looked at how we can treat men with non-metastatic castration-resistant prostate cancer. The first one is ARAMIS, and in ARAMIS, the men that were at risk were that high doubling time, good performance status for the trial, and PSA above 2, and no metastases, or they could have some pelvic lymph nodes. The other trial was Spartan, and the other trial was Prosper, all looking at different drugs, darolutamide, apalutamide, and enzalutamide. And what I think is really interesting there, look at the data here. All of them looked at the difference between placebo and their respective drugs. But you can see for these high-risk men, the placebo group, so the ones that were just on ADT, progressed or got metastases somewhere between 15 and 18 months of treatment. But with treatment, with darolutamide or enzalutamide or apalutamide, that went right up to 40 months, 36 to 40 months. So you can see for these high-risk men, it's really important to recognise that there is actually treatment for them. And that's important when we have those conversations. So let's look at the challenges that looking after these men might bring. And it's good to just think about goals. So for patients, generally, patients want to live longer, but they also want to feel better and maintain their functional activities. And for us, we want that as well, but we also are trying to facilitate that whilst juggling things like patient preferences, available treatments, side effects, disease effects, and all those other things that come into our consultations and our decision-making process. So when we're looking after these men, there's a challenge around identifying them and just sort of working out what's going on with them, and also making sure we're looking for the right things. We've got treatments for these men now, so it's really important that if we're looking after them, that we are aware of things like doubling time, and that we're highlighting the men that may benefit for further treatment. But it's more than that, it's also about quality of life, and what are we doing to make sure that their quality of life whilst on ADT is maintained, both because of the drug, but also because of some of the challenges that Alex has already talked about earlier. For me, identifying patient goals and preferences is really important as well. It's rarely a one-off thing. It's something that develops as our therapeutic relationship with our patients develops as well. And also how we can make sure they've got access to treatment. And some of that's knowledge, both for us and for our patients and their families. And some of it's around identification, early referral, and making sure that our patients are as fit as possible. So how do we rise to those challenges? Probably the most difficult thing. So if we think about what's happening to these men, they're having their PSA check, the doubling time, their testosterone, we might be doing imaging, and all that's about monitoring. It's all about that sort of medical model of just, looking at the numbers and the data and sort of guiding them through that. But I think there's more to it than that. There's some other bits. There's a performance status, there's their choice, there's a psychological health during all this, and it's how we refer, and all these are modifiable. And this is, I think, where we come in. So if we think about that time on ADT, right from initiation through to all the treatments, that time when men are on ADT as their monotherapy is an ideal time ideal opportunity to optimise health and well-being. And there's a few ways we can do that. The first one that we often think about is how do we help the impact of the androgen deprivation therapy effects? And the benefit of thinking about that, how can we mitigate some of those side effects, is about quality of life. ADT is a really tough treatment for many men, and if we can help them manage those effects, we might be helping their treatment adherence, and really importantly, we might be helping mitigate some of those long-term metabolic effects, because we know that ADT can affect bones, it can help affect cardiac health, and it can affect overall health. By definition as well, a lot of these men will come to us with various comorbidities. They might be on lots of medications, etc. And again, the time on ADT is an ideal time to really look and think about how can we optimise their health. If somebody's got a poor performance status, if they're on ADT, it's an ideal time to review their health, to get them reviews with relevant services, and be really proactive about how we can make sure that they're engaged with other medical colleagues, with exercise, with physiotherapy, with all those things that will really help them improve their health. The other thing we can really think about is self-efficacy and adherence. And self-efficacy is that ability to look after yourself and self-manage. And this is really essential because so much of what we ask men to do, right from turning up for their blood tests, engaging with follow-up, managing their side effects, initiating behaviour change, all requires an ability to do that for yourself. So anything that we can do to engage men with behaviour change, manage their side effects, again, can help with adherence to treatment. And this really comes under the banner of healthy living. As Alex said, you know, sometimes, you know, normal worrying can be a real trigger to think, okay, what can I do for myself? And if we can facilitate and encourage and help people to engage in new exercise habits, engage in their general health, it might improve their access to further treatments down the line. So I think this is really a challenge. I mean, I think sometimes, you know, people get started on ADT and we get quite sort of, you know, onto the treadmill of PSAs and quick consultations, etc. But this is really a massive opportunity. And for patients, it's something they can absolutely do for themselves and really get them to the habit of engaging with their health. So if we look back at our pathway again that we looked at earlier, let's look at some of these key points. So at diagnosis, there's a real opportunity here to start that therapeutic relationship. In the UK, we do holistic needs assessments and care plans, and that's really a way to get our patients and their families to identify what their unmet needs are and what things are really bothering them, so we can start to care plan and we can start to find ways to help them with whatever's bothering them. It's also a really good place to start to talk about education, about treatment options, pathways and triggers for investigations. And I was really struck by what Alex said. These men, by definition, are living with fear of recurrence every single day because they know they're on treatment that isn't curative. It's something that just keeps things under control. So anything we can do in terms of listening and validating those fears, educating them about triggers, educating them about what we're doing and why we're doing it, helps hopefully mitigate some of that fear, but also helps engagement with things like PSA monitoring. When we start treatment, again, it's an ideal opportunity to introduce things like education programs so that we're really thinking proactively about side effect management and bone health and cardiac health. And we're right from the get-go, we were really talking to men about how they can manage things themselves and how they can access care and support. And also the importance of logistics of monitoring, including self-management. During follow-up as well, again, an ideal time to introduce other services, things like physiotherapists, pharmacists, older persons team, the general practitioners or their family practitioners, to make sure that they're really engaged in anyone that can really help maximise their health. Then when that PSA does rise, it's really important that they understand the significance of it. And again, what Alex said before, you know, it's normal to worry. It's absolutely normal. But if we can use the data that we know about, we know what high risk looks like and we know what low risk looks like. So educating men about what their PSA rise means can sometimes help that fear and help them live more comfortably with it. And then that holistic support, I mean, that goes right the way along. And I think, you know, Alex mentioned before about things like peer support. And I think support groups, other men going through the same things, other partners going through the same things are really important. And it may not be something they want to engage with at the beginning, but having it there in the background and, you know, consistently offering it to them, the right time will come eventually. And it's important that they know about it. I'm a clinical nurse specialist, so by definition, I think access to a CNS is probably one of the most important things that men can have. But it is about that point of contact. It's about somebody to talk to. Our fears don't happen every 3 to 6 months when we have an appointment. So it's having that access to talk to people when it happens and really make sense of what's going on. And then obviously ongoing input with side effect management and education is absolutely essential. So you can see right the way through the pathway, there's so many interventions we can do to maximise our health, but also take some time to really think about what's important. And just to go back, and I think, again, this really speaks to what Alex talked about earlier. We know that for men with metastatic prostate cancer, we've often just monitored things. We just basically waited for metastases to develop. And for some men, that's positive. And not having metastases is all the news they need. But for some men, it does cause anxiety, hypervigilance, particularly if they've got that high risk disease. So it's important to understand that may happen, and all those interventions that Alex said may be really useful. So mindful of the time, the patient support, choice and support is absolutely essential. And I think in terms of the psychological management, what's the plan? Why are we doing what we're doing? What's important to you? What can you do to help yourself? Peer support, etc., is absolutely essential to try and mitigate some of the things. And as Alex said, just listening and validating what they're going through, because this is a lifelong condition. And as I said, the fear of recurrence is something that these men live with every day. So I think if you think about the goals of men, you know, to live well, live better, live longer, there is a challenge. And I think a big challenge is a change in the way we manage their pathway. It's really important that we identify who will benefit from treatment and identify that early and know what those characteristics are. But I think it's absolutely essential to make sure that men are aware of those options right from the beginning, and also change how we communicate the significance of PSA. What does it mean? What does the rate of rise mean? And what are we going to do about it? Because, you know, that PSA is really important to patients, and we need them to be able to understand the significance of it and what we plan to do. And as I said before, and I'll say it again, that time on ADT is an absolute opportunity to support, educate and optimise. And we're thinking about improving their performance status in general health. We're thinking about minimising the impact of side effects. We're thinking about preventing those metabolic effects and promoting self-management. And at the end of the day, maximising the options for further treatment later on. And if you're interested, we've got a programme supported by the EAU called lifeonadt.com. It's an education programme, a 1.5 hour seminar and a book. We're open to any patients. So if you've got any patients that might be interested in the seminar and the book, you can direct them to lifeonadt.com. You can scan the QR code there on the left and just download the website. And men can just go onto that website or use the QR code and they can register for a class. We're running pilots in the UK at the moment, but we're very happy to take patients as long as they speak English. Sadly, my foreign language skills aren't up to a lesson in Danish or French, but they're very welcome to come, and we're hoping to roll this out more widely as well. So I'll stop there and I'll stop sharing my screen. I'm going to hand over to Nicole, and hopefully we'll be able to have some questions later.
Good evening, everyone. My name is Nicole. I'm a case manager at the Uro-Oncology at the Medisch Spectrum Twente, that is in the east of the Netherlands. We are the largest non-academical hospital of the country. And I work there as a case manager. And as a case manager, I'm the contact for patients during treatment. And I have no conflict of interest to report. I'm quickly going to run through the definition of castration-resistant prostate cancer, because I know Louisa had mentioned it before, but castrate serum testosterone is necessary, plus either a biochemical progression or a radiological progression, and symptomatic progression alone is not sufficient in diagnosis of CRPC. So what really happens in CRPC is that it simply means that the standard hormone therapy doesn't work anymore, and that the cancer is growing, and prostate cancer cells grow in response to stimulation of the androgen receptor. So really, we know that the tumor and perhaps metastases continue to grow because the prostate cancer cells no longer respond to hormonal castration treatment. So then we look at the timeline, and we need to know where on the timeline is the patient. Pre-metastatic, or is he metastatic, and is he asymptomatic, or are there side effects, are there problems? We need to find that out. So in order to find that out, we use imaging, and we use the CT scan and the bone scan. Now in my hospital, we also use the PSMA CT scan. But I understand that's not the golden standard, but we need imaging. So after imaging, we discuss the patient in a multidisciplinary team, and that consists of a nuclear medicine, a radiologist, an oncologist, a radiotherapist, a pathologist, and of course several urologists of the region. We need to determine what will be the best treatment, depending on whether the patient is asymptomatic or not. So there are different options available, of course, and I will not go in to that very deeply. But what is really important is to know that the head practitioner moves from urologist to an oncologist, and it's always they stay under the control of the doctor very carefully. So, and it's very important that they know that should there be any problems, or if they have any problems of side effects, that they need to contact us immediately. So my role as a case manager is that when they contact me, that I make sure that the doctor knows right away what's going on. And also, you know, first of all, you know, the disease, as well as any treatment, can give physical discomfort. So patients need to know when to call and that they should not wait with any problems. Now, there are many problems that can occur with CRPC, as well as, of course, the lower urinary tract problems like bladder obstruction or hematuria, or the upper urinary tract problems like hydronephrosis or sepsis. And also we hear a lot of LUTS, nocturia, or urine incontinence. So we must not only look at the physical problems, but also at functional well-being. So what can we do for the patients? What is very important in this part is also the social and family well-being and emotional well-being. So I always discuss with the patient on what department do they need support. Of course, we all know that it's very important that they keep as fit as possible and maintain a healthy lifestyle. We know that if they keep as fit as possible, it can have a positive effect on the quality of life, since treatment can cause many side effects. So we also discuss, do they need support? Like, can they do sports? Do they need support in that area? If they're very motivated, but for example, have a poor physical condition, I ask them if they want some coaching from a physiotherapist. Also, do they need coaching from a dietitian? Some people have trouble in maintaining a healthy weight due to the side effects or perhaps of pain. In Holland, it is so that 3 hours from a dietitian will be paid for by insurance. So perhaps that will be enough, you know, to set them on the right track. And also, would they benefit from coaching by a psychologist? You know, for some people, it would be absolutely helpful, but for some also, it may feel like it's a bridge too far. In that case, we could look if they would like some coaching from their general practitioner's office. In Holland, most general practitioners have a psychology nurse on staff as well. And a lot of men, and sometimes the partners as well, could benefit from contacting a patient's association and come in contact with men who have the same situation, the same problems. That can be very beneficial as well. Sometimes it's very hard for people to accept that they're coming into the last stages of their prostate cancer, and expressing their feelings and experiences can be very helpful in the acceptance process. What is very important also is not to forget to include the partner. I also encourage them to keep the intimacy and the communication alive during this phase. Also because there's very little activity usually on the sexual department. Therefore, the intimacy and the communication is even more important in a relationship. And it can be very helpful to talk with each other or to others about the emotions and the wishes. And also the partner is very important in itself, because usually it's the biggest support system for the patient. And sometimes the partner can feel overwhelmed as well. So it's important that they know where they can turn to should they feel overwhelmed or run into issues. So in Holland, it's always possible to go to the general practitioner and ask for psychological guidance as well. Thank you very much. That was my presentation.
Thank you very much, Alex, Louisa, and Nicole, for very interesting presentations. And I would just like to say that we would thank Ibsen for this webinar. If it wasn't to Ibsen, we couldn't have done this tonight, to ask you to do your very nice and interesting presentations. As far as I can see, we don't have any Q&As at the moment, but to the audience, please feel free to send any questions to our presenters. And meanwhile, you figure out your questions. I would just like to ask you, Alex, what is your best advice to nurses who work with patients who they presume deal with fear of cancer recurrence or fear of disease progression? You might have been talking about it in your presentation, but to a clinical nurse who stands there in the outpatient clinic or in the department, what is your best advice?
You know, the first thing is just to kind of recognize that it's really difficult, and we do a lot of you know, a lot of sort of reflective practices vision with our kind of clinical nurse specialist colleagues, and kind of responding effectively with sort of compassion and kind of care and the due attention in that kind of corridor conversations are really difficult. So the first thing would be, you know, it's okay to not be able to do everything in that moment, right? It's sort of okay. I know that people are, you know, really, really compassionate, and they sort of really want to address people's sort of fears and thoughts immediately and not let them hang and not let people go away fearful, but just to sort of say it isn't necessarily that it's the best timing to do this. So often my first bit is kind of, is the setting correct? You know, do you have a place to sit down? Do you have the time? If you're in a rush, you're probably not going to be able to be really listening and caring. You're probably going to be just sort of trying to move on. So make sure that the setting is kind of safe, and you know, explain to people that this is an important topic, but right now is not a good time to really delve into it. Now, if you do, then I would go back to those kind of things about first, really, really listen to those fears and sort of make sure that you don't actually answer any of the fears to begin with. Spend a lot of time just sort of really listening and also kind of going, and tell me a bit more about that fear. And, you know, where does that fear come from? And, you know, kind of, you know, really, really sort of until people are literally starting to repeat themselves, and then summarize back and say, okay, so your fear is about this, about that, and you're thinking this, and what's happening is that. Have I got that right? So if people are feeling really heard, then they can hear you back. Otherwise, they'll just keep saying their stuff, right? And then the last thing would be going into those things we talked about, you know, information, education about checking, and beliefs about worry, and, you know, advice and direction about how to handle things. And I think also, you know, like Nicole sort of said, is, you know, sometimes people, even if they're really struggling psychologically, it's not the easiest thing for them to sort of accept psychological care. So I think kind of introducing that idea very carefully with perhaps a kind of, you know, what are some of the ideas that people have told you about how to deal with anxiety? Yeah. And then we might say, oh yeah, well, they told me about talking to a psychologist. And then you say, well, you know, what do you think of that idea? So you've not really introduced that idea, so they can't really push away, but, you know, they're thinking about it, and you're having that discussion. So, you know, it isn't necessarily the case that that's better care. In fact, very often the best care is for people to sort of maintain that dialogue with their nurse specialist. But you know, sometimes it is appropriate. So, you know, again, just very important to just really be aware that you can't sort of immediately, very quickly solve these things. Not if you're feeling under time pressure, not if you're feeling rushed. You know, you need to respect your own time and space as well in this. So I hope that little recap is helpful. Thank you, Brigitte.
You're welcome. Thank you, Alex. And now we have a few questions in our Q&A. Jerome, Marley, thank you. All the three presentations were very insightful. Can I ask each presenter, are there any available tools that you could recommend for nurses to integrate into their care, in addition to the course Louisa mentioned?
Do you want me to start?
Yes, please.
I think that's a great question, Jerome. And I think there's lots of things. I think for me, probably the biggest game changer for me was looking at behaviour change, things like motivational interviewing. So what I found really interesting was the idea of, I think everything Alex said, sitting back, the best thing you can do is listen. And as Alex said, until someone feels listened to, they're not going to listen to you. So allowing someone to tell their story, just listening in a non-judgmental way, using all those sort of reflective skills, empathy, and then listening out for that change talk, listening out for anything that shows a desire and need and ability to change, and then going on that and allowing people to identify themselves what their fears are, and then what they're capable of doing in order to address them. So for me, I think of all the things I've done, learning about motivational interviewing was probably the most powerful. Because it's not just about making people change, it's also about just having those skills to sit back and allow them to discover things for themselves. So yeah, that would probably be my thing, and obviously my ADT course, which is also based on motivational interviewing.
Yes, thank you, Louisa. And here's another question from Louise Dorner Østergaard. Do any of you use PRO, patient-recorded outcomes, to follow patients and give them individual treatment and monitor symptoms and decline in quality of life? And if you do, what is your experience? Who's going to answer that question?
I mean, it's not something we use regularly in clinic, apart from, I mean, the holistic needs assessment is a form of PROM. So we would certainly use that in order to start the conversation going. And in theory, it's something that we can use along the pathway. I'm a big fan of PROMs. I think they're great. And we do use them in other services. So our prostatectomy follow-up, for example, is PROM-based. And the radiotherapy one as well is going that way. In advanced cancer, it's not something that we've integrated yet, but I'd love to hear from anyone that has. The main issue is just time, and I think that's a poor excuse, but unfortunately it's also reality. So yeah, I mean, if anyone wants to put in the chat box if they've had any great experience, that would be really good to hear about. Nicole, do you use any PROMs in your practice?
No, not yet. We're starting up, just starting up with that. Yeah, so I can't really say a lot about it.
Yeah. It certainly seems to be the hot topic, and I think in terms of our localized follow-up, it certainly has brought some benefits, but it doesn't come without its challenges, particularly men's ability to use them. So sometimes you have to sort of adapt it to the the sort of health literacy and the ability of people, but I think they're a good starting point. They're a good springboard because it gets people thinking about what's important to them, and that's always a good place to start with any conversation.
Thank you very much, Louisa. And from Aslan Demi, does the loss of erection capacity after treatment have additional stress apart from the other cancer? And how can patient deal with that problem properly? And thank you very much for this meeting. I was wondering, Nicole, would that be a question for you?
Yeah, let me just make sure I understand the question right, because the men who are on hormone treatment already experience a loss of erections. So that changes the whole dynamic in a relationship, but also in their self-image and how they perceive themselves as being man or manly. And in my experience, that is not particularly the same as going into a metastatic stage of the disease. So most men have already come to terms with their loss of erections, and it's not really that much of an issue because people are more interested in their survival, and that's and keeping a quality of life. So I always say, what's very important in a stage, and if you have a relationship, are three things. Obviously, one of them is the sexual aspect, but also the communication and the intimacy. So if there is a lack of the sexual part of the relationship, the other two aspects become even more significant. So I try to engage the partner as well, and encourage them to keep the communication lines, between them open. And, if they experience any troubles with, in the relationship, I refer them to a specialist for that. So I always discuss it with them, and I repeat it often as well, so they know, should perhaps in a later stage come problems, that they know they can discuss it with me and that I can further help them.
Thank you very much, Nicole. So we get another question from an anonymous attendee. What kind of education would you suggest to nurse specialists, as there is not much education provided on psycho-oncological path to support patients? There is no study modules or pathways, as there is a lack of psychology professionals in all areas of hospitals, less resources. So, Alex, would that be one for you?
Well, I mean, obviously, there's people here from kind of across a wide range, right? I mean, there are particular types of training for nurse specialists in the UK, what we call kind of level 2 psychological skills training. But you're right, it will really depend on your kind of local your local resources. If you do manage to find or have access to sort of any psychology expertise, I think one of the most high value interventions is not seeing patients, but spending a lot of time with staff, kind of helping their skills and understanding kind of to develop, because obviously as CNSs, you'll see all the patients, and therefore everybody will benefit from that. But when you really don't have anybody, that's understandably really, really hard. Nothing can kind of quite stand in for that. Nothing that I know, to be honest, that could take, that a CNS could take independently, to be honest. But it's, it's a sort of an interesting kind of question when we do these, international things, and I'll look it up, to be honest. Now, yeah, that's a very fair question.
Well, thank you, Alex. And Salian Wildman, do you have any advice on follow-up of these patients? We phone a couple of times and leave to the patient to contact us if they have questions. Any idea or advice? Should phone a third time or leave it as is? I don't know, Louisa, is that a question for you?
I don't know if I understand the question. So follow-up of people that are worried, or, I mean, sorry, it's probably me, I just don't quite understand the question. I mean, generally, I think if somebody phones in for advice, I would probably try quite actively to get in contact with them. However, time is limited. So, it's a difficult one. I don't know, because I don't really understand the context. I do apologise. In fact, Sally, if you want to could you just maybe type in and clarify exactly what the question is, what sort of patients you mean, and then I'll try my best to answer it. I'm sorry, I feel like I'm waffling.
You're right, Lisa. We can maybe take another question while Salian is clarifying the question, so we can just move on meanwhile. Nicola Lancaster, Macmillan are offering free. Oh, sorry, Alexa, you were about to answer that question.
I just was marking that I would like to do it, because there's a similar kind of question there about when people have severe. There's another question from Amelia that people have severe issues, but there's long waiting lists and no help available. Do we recommend self-help? And I have a feeling about this, because we wouldn't kind of go, well, you have severe urinary incontinence, but we haven't got a long, waiting list. Can you use an app? Like, you wouldn't do that for physical symptoms. It's just not acceptable. But, that will be the reality. And I think, you probably also want to sort of respect the fact that for people, when they really do feel sort of severe, it feels kind of somehow, sort of perhaps invalidating to sort of say, well, there is this app, right? It really doesn't, in my experience, that's not something that people are sort of severely affected. Now, however, that said, there can be, and almost by definition, right? you know, these things kind of, you'd reach for them if people have kind of sort of these are problems for people. So, you know, I don't really think that they're, you know, a huge kind of fallback when you don't have actual sort of capability to refer to clinically. They might be helpful for people who are trying to develop themselves, right? So they have that kind of self-efficacy that Louisa was talking about, the people who are like, what else can I do to improve my health? If they're in that space, then apps can help them. But if they're in the space of, I'm overwhelmed, like, have this app, or, you know, I don't know, if somebody sort of said that to me, I mean, you know, I wouldn't feel so good. And they're not really tested for sort of severe cancer anxiety, right? So I'd be very cautious about doing that unless you really, really run this yourself and you're very, very confident with what exactly it does.
Yeah, thank you, Alex. And Nicole, you would like to answer Amelia Barber's question, and I think that might be the last one as the time is about to run up, but please, Nicole.
Yeah, I actually have a few patients who are really anxious and demand certain treatments or referrals to certain clinics, everywhere in Europe, or, you know, excessive PSA testing. And I always find it very interesting. And I really want to know from the patient, where does it come from, really? Some patients really want to stay in control of the situation, and the way they express it is that they are the ones who decide when what happens instead of the doctor. And most of the times, you know, this anxiety comes from, you know, fear of progression, fear, and probably fear of dying. So I always try to see with the doctor and the patient, you know, how can we accommodate for the patients, you know? If it's really a question of staying in control as much as possible, then I always try to see and find a middle way. You know, is there room for that or not? You know, if there is room for that, and the patient really, you know, wants some things, you know, or an extra PSA testing, sure, why not? You know, if it helps them and keeps their anxiety more down. So I'm all for that. But, you know, we can't always give in to everything. So the patient needs to know, you know, we always try to see and work with the patient and see what is possible, but sometimes it's just not possible. So it's always finding the middle way.
Well, thank you, Nicole. We do have time to answer more of the questions while we just go through. From Said Mohammed, which are any exercises useful for reducing pain in prostate cancer? And I don't know whether this is like, you know, physical exercise, or what do you mean by this question? But yeah, we do have experience with patients who come to see us with musculoskeletal pains, and when they get a tailored exercise program planned by a physiotherapist, they can actually reduce their pain. So I hope that was what you meant by your question. And Ketin, social isolation, depression, etc. In such cases, would you recommend medical treatment with psychiatric agents? And I can see that Alex is typing an answer for that question.
I have an addition on that as well.
Yes.
So after you, Alex.
Oh, good. Of course. I just want to say that, you know, it can be appropriate, but it needs appropriate clinical assessment. Kind of what I'm a little bit against is kind of, you know, for urologists or oncologists to kind of just throw the odd bit of kind of sertraline in there, because you know what, we're just throwing chemo at people. What's a little bit of an SSRI? But you know, it really isn't an appropriate assessment just on the back of, you know, I'm feeling sad, etc. So they need an appropriate clinical assessment. Medication isn't always indicated. It's really only effective in quite sort of severe instances, and it needs quite appropriate monitoring. If you have the appropriate resources for clinical assessment and sort of monitoring, you should appropriately consider that. But don't do that because likely it's the only thing you can do. It might not be appropriate. You wouldn't do that for physical health symptoms.
Yeah,
Nicole.
Yeah, I just wanted to add, there are a lot of elder people that live in social isolation. So I always try to see and let them have an active part in this, is to see, can they take up hobbies? Can they go out? Can they, find something with like-minded people where they feel at home, so they get out of the isolation? Because sometimes it's just a course of life. And how it's run, and it's not really like something that they have they've wanted per se, some people take up voluntary work just to get out and go to patient organizations where they can drink and meet other people who have cancer as well. So that can be very helpful for some people as well.
Thank you very much, Alex and Nicole. And Louisa, you would like to answer the clarified question from Salian?
Yeah, just thank you for clarifying. I'm sorry I didn't understand it the first time. I think so. You've said we follow up on all our patients starting with hormone therapy, but how long should you continue to do this? So I think it depends on what kind of model you're using. So where we are, quite often those patients, their entire care will be nurse-led. So we would, by definition, be following them up regularly. But it's an interesting question because it wasn't that long ago that actually we would discharge them. And I feel quite strongly that that's not the right thing to do. From my experience, the needs of these men don't go away after one or two kind of consults. It changes as it goes along. The anxiety changes, the stress changes, the symptoms change, and the long-term metabolic effects make themselves known quite a long way down the line. So for me, it's an ongoing thing. I'd be very disinclined to discharge anyone on hormone therapy now unless it was their choice, they were stable, and I felt like they had all the education to self-manage and they had a route back into hospital. But if you're talking about people that are already under medical care and this is a sort of nursing thing, I think you just have to think about what your resources are. Again, I'd say ideally, I'd want to proactively look after these people because unfortunately, the people that need us most are probably not the ones that call. So it's how we make sure that there's a good safety net there and that access is there and are not completely dependent on someone reaching out, because some people by definition aren't able to do that.
Totally agree with that, with you on that, Louisa. Yeah. Yeah, so the last question for tonight from Yao Xin: how to decline prostate cancer patients' anxiety? Could you give me some detailed example? Thank you. Yeah, who's gonna answer that one? Alex, is that you or?
I mean, decline, I suppose that, you're kind of sort of address perhaps, or kind of reduce, right? At the risk of kind of keeping everybody too late in the night, I'd say to sort of probably just maybe rerun the video with the advice from the sort of social worker I have embedded in the presentation. I hope those will go up. When I looked at that, it's kind of really quite nice. It sort of speaks to the patient directly. So you'll probably get like some of the detail that you're looking for and how to put those kind of concepts into words for the patient. So that's probably the kind of quickest answer without keeping you here. As you can imagine, as you've seen, I can probably stay here and talk through the night. It would be lovely company, but I'd better not do that.
I'm sure you could, Alex, and we would love to hear you, but unfortunately time is up. So thank you very much for your very interesting presentations and your knowledge and your experience with these patients. It's very valuable for all of us. So to the attendees, I hope that you like this presentations and your as you know, you get credit for this, for the participation tonight. And we hope to see you again at another EAUN webinar. Have a good night, all of you.
Good night. Bye.